the rest of our good family here today. Really excited to be here, and I just wanted to give a brief introduction for Dr. David Crumpacker. Dr. David Crumpacker received his medical degree from Cornell University Medical College in New York City before completing a residency in general psychiatry at the University of Texas Southwestern Medical Center at Dallas. He then completed a 2-year fellowship in geriatric psychiatry at UT Southwestern, and now is currently enrolled in the MBA program at Harvard. When not engaged in care of his patients, Dr. Crumpacker enjoys time with his 21-year-old daughter. He is an avid participant of CrossFit and a linguist with proficiency in Spanish, French, Russian, Mandarin, Hindi, and classical Greek and Latin. That's it. But we'll do it in English, yeah. That was better. And again, thank you for having us. Excited to be here. It's a privilege.
Absolutely. Thank you, Cameron. I could not have written a better introduction myself. So, actually, I do tell people that I get asked all the time from residents, medical students, will you write me a letter of recommendation? And what I tell them is, write it yourself. You'll get it done a lot faster. I promise that you will, and I'll make it my own. Again, I'm glad that everybody here is interested in working with seniors. I'm going to share with you something that a patient had said to me, maybe a couple of months ago. She turned 8, and she was worried about aging, as we all do. We all face the changing seasons of our lives and wonder how we do it with each milestone. And she said, something that had occurred to her is that we all get the chance to be young. Not everybody gets the chance to be young. What I thought was an actually very profound thing to say. It puts things in a lot of perspective. Everybody in this room has had a chance to be young, but when we have a chance to be old is something else. And so I'm glad that you all are focused on this. Karen, as he introduced me, I'm a geriatric psychiatrist, board certified. And do you know there are only 4,000 board certified geriatric psychiatrists in the United States? And share with you a couple of statistics. The population of the United States is about 350 million. Of that, maybe 8 million people are over 65. 80 million people with 4,000 geriatric psychiatrists. Plenty of job security for me. And bringing it home to Collin County, I'll say it this way because I was at Baylor. I was the assistant chief of psychiatry at Baylor downtown for about 15 years. And when I decided to move my practice to Collin County, my colleagues thought, Collin, tell me, it's filled with kids up at Collin. I say, well, perhaps. But what I thought is, and now know that, maybe kids, maybe all the yuppies in Collin County have kids, maybe they don't, but they all have parents. And this is the majority of my practice, people coming from Rust Belt states where they're relocating because their kids now live in Dallas, their kids live in Plano, and suddenly relocating dad or mom here. And we'll talk about this in a little bit, but that just adds to the isolation of our patients. They're already isolated, and you're picking up mom from Indiana, moving her to Dallas. She had a church, she had family, friends, and moving her here because it's easier for us. And certainly it is. I'm not disparaging that. We're just emphasizing the isolation that presents. And by the way, I think we all need friends. We all do. It's not the same as going to you. Well, my mom thinks she'll go to prom. My sister will go to prom. If we come on. It's the same thing by saying, well, I can go with my kids and be with their friends. We all need friends ourselves. So I wanted to talk a little bit. You've got it up already. And I asked them to move this so I could walk in here. I thought it was a little bit awkward standing up there. And when I came in, everybody was sitting at the back. And I thought, it was just like church. But people in bad eat at the Lowe's.
Wow. You keep it there.
They need to hear the good news. That's than the people up front who have already heard it, right? So I thought it would be a little bit better to kind of walk back and forth. I want to start also by saying that it is never normal to be depressed. I think most of us in mental health know that. But I'm surprised how often I say that. People say, turn on the news. That's depressing. All you have to do is watch the chaos and watch it. That's depressing. I guess, but that's not what I mean when I talk about depression. And I want to reserve that word for a medical entity that has reliability in diagnosis, and response to treatment. Very much in the same way, like I might say, is it Neil? Neil, if I said, Neil, I got a call from you, an IRS agent who asked if I knew you, and if I knew you could later tax. And I said, I pay my taxes and I encourage Neil to do so likewise. I don't know anything about it. If we checked his blood pressure right now, it might be elevated. Or I know you all do this when you get home and you see a letter from the IRS, don't you? Just for a second. Or you see the lights from a cop car in the background. Just for a second, you look at the speed limit, your blood pressure goes up. That is not the same thing as saying you have hypertension. Your blood pressure is elevated. Hypertension is a complex medical illness of many symptoms, one of which is elevated blood pressure. But it's related to an awful lot of other things. In the same way, when I say depression, I'm talking about a medical entity. I'm not talking about what someone might feel through a breakup or the loss of a job. Someone could get depressed with that. Not necessarily. I shared this with you because we're talking about seniors. Did you know the incidence of depression actually drops as we age? It drops. And the reason for that is that depression, and I'll share this with you in just a little bit, associated with medical illness, a lifelong history of poorly treated, untreated depression is not conducive to making it to 80. It's not. It's the same with we're seeing these days fewer and fewer Holocaust survivors. But did you know the incidence of depression in Holocaust survivors is very low? Mm-hmm. And of course it is, because if you were depressed during the Holocaust, you didn't live. You weren't a survivor. You couldn't be depressed and make it through the Holocaust. It self-selects for people who probably are not depressed. The same way with aging. Remember I said earlier, we're lucky if we get to be 80. Yeah, very lucky if we get to be 80. And that's not conducive to a lifelong history of depression. All the more reason when I say this is Johnson, who's 80, is depressed, all the more reason to treat. So often, and I'd even heard in my own family a number of years ago when my grandmother had macular degeneration. She couldn't see. My grandfather had passed away. She was in Florida, didn't want to move to Dallas. And I said to my mom, I think grandmother's depressed. Well, of course she's depressed. She's old. Since when did being old have anything to do with being depressed? And actually, from the statistic I shared with you earlier, chances are you're not depressed when you're old. All the more reason to treat it. To me, that would be like saying, well, of course somebody developed an osteomyelitis. They tripped and fell, got an infection, cellulitis, fasciitis, and they developed an osteomyelitis. Does that mean you don't treat it? Because you understand how it might have come about. Treat it. Of course you're going to treat it. You might understand a lot of factors that play the role in the depression, the isolation, the macular degeneration, which simply adds to it. Moving from Florida, it certainly we talked about this before, the changing seasons of our lives. All of those things add to it, but most people don't get depressed. All the more reason to treat somebody if they're wrong. And certainly when we're talking about in a nursing home setting, those numbers skyrocket to maybe 40% of people in nursing homes will have clinical depression. And they're not depressed that they're in a nursing home. That implies 60% people in nursing homes over 65 aren't depressed. So it's never normal to be depressed. Sometimes I think in psychiatry we hammer that by how untreated and undiagnosed depression is, and that's true. But then we kind of come away thinking, well, everybody's depressed. Everybody. No, not everybody. In fact, most people aren't depressed, and most people don't get depressed. And if they do, you'll have to be treated. Thank you very much. Is this Danielle? Cameron, yeah, thank you very much. Remember I said a little bit earlier that it's never normal to be depressed? It is true that depression compromises the morbidity and mortality of every medical illness that we know. Whether it's stroke, whether it's heart attack, Parkinson's disease, and in fact, there is not a neurologic pathology that I can think of that does not have a psychiatric protocol. Being that initially somebody presents with psychiatric illness and later we find out, they've got Huntington's disease, or they've got Parkinson's disease. 70% of Parkinson's patients will be depressed. 70%. And that's a lot. And by the way, it's not correlated with the extent of the Parkinson's. Meaning they're not depressed that they have Parkinson's disease. It's immaterial, it's not related. Kind of like Robin Williams. Robin Williams, of course, we knew he had bipolar disorder. Absolutely. But the incidence of suicide in bipolar disorder is extremely high. He didn't do it until he began developing Parkinson's disease. And probably the same thing that causes Parkinson's disease causes depression. That's probably the way we think about it. About 75% of patients with Huntington's disease will get manic. That's why we often say most psychiatric pathology are diseases of young people. They really are. Remember I was saying earlier, you don't get to be 80 and have lifelong psychiatric pathology. You don't. But if you do, you ought to raise some questions. You ought to think about it. Suddenly, for a 60-year-old to get anxious or psychotic, something's going on. And it's not rapid, late onset schizophrenia. I had somebody say that to you. Rapid. Late schizophrenia in a 60-year-old? I doubt it. As opposed to, 20, okay, but 60. I had a patient once and he told me, my kids don't talk to me because I divorced their mother. She died of Huntington's disease, and they tell me, you diagnosed mom because she had Huntington's disease. And he said, no. Oh, I'm sorry, yeah, you divorced mom because she had Huntington's disease. And he told me, no. I divorced her mom because she slept with 5 of my friends. She got manicky 10 years ago, manicky out sleeping around, divorced, and then later diagnosed with Huntington's disease. Which also kind of brings up another point. It really is the psychiatric pathology. It causes morbidity, impacts people's lives. Nobody divorces because they had a stroke or because you got brain cancer. Can you imagine? Why did you divorce it? SOB got brain cancer. Would you divorce the SOB? No, because his personality changed because of brain cancer. He develops behavioral disturbances, psychiatric pathology because of it. That's why that happens. Did you also know there are serotonin receptors on platelets?
Yeah.
It's kind of cool, isn't it? We knew for a long time that if you have stroke, if you had a heart attack and were depressed, you didn't live. You had another stroke or another heart attack. There are actually serotonin receptors on platelets, meaning that people who are depressed don't cloud as well. You're more likely to have another event if you're depressed. I'm not saying everybody who has a stroke or a heart attack needs to be on an SSRI, Prozac. I'm just saying that you are related. And that's why we can't treat mental illness in isolation. Keep going ahead. It can't be. And some of these reasons up here are reasons why our seniors don't get treatment. Maybe 50% of people, and that's a lot. I mean, we talked about the population of the United States. I'm sure you know the population of Collin County is about 1.5 million people. And of that, 10% are over 65. Do you know that? 10%. It's 150,000 people, and on that 50% probably aren't getting treatment. There's a lot of work for all of us, plenty of work for all of us. What are some of the burdens to that? I mentioned one a little earlier, and that's that preconceived idea that you're old. Come on, Mary, she's old. It's depressed. Wouldn't you be? And now you're armed with the knowledge of, I probably would be depressed. In fact, most seniors aren't depressed. If they are, they ought to treat us. That's a factor. Isolation, I mentioned like my grandmother, but all of my patients who are down, half of my patients over 65 have been relocated here to Dallas. It's a kids live here. Had a patient yesterday. How'd you get to Dallas? From San Diego to Dallas? Really? Why? And she said, but my silence here. And it's getting harder and harder for him to fly out to San Diego all the time to take care of things. So I agreed to move here. I was looking for a place to live. Isolation. And also that digital isolation, right? If we talk to a patient, she's like, right click. What do we like it? What do I mean, right click versus left click? I had a patient, he was a colonel in the Air Force, when he retired, he flew 747s. You all are too young to remember 747s. No, we're not. And you don't know what you remember you also 747? Oh, I hate young people.
I know. You can make now. It's unpredictable.
You said this? I hate young people. But we had Led Zeppelin, Pink Floyd.
That's right.
Man,
Best music ever.
they had Justin Bieber.
Yeah.
You'll see.
That says it all right there.
On the 70, I was fighting to approve. These were smart doctors, just finished their training, family medicine doctors. And I brought up James Brady. And someone says, who's James Brady? That's common. That's not an uncommon name, but this is Ronald Reagan's best thing right there. Shot when Ronald Reagan shot. None of him, because Ronald Reagan wasn't shot.
Oh my gosh.
Dude was shot, right? Shot, right? Okay. He wasn't shot to death, but he was shot. And this little punk said, I was born in 1981. And I said, well, I was born in 1865, but I never won to some war. It is an excuse. Don't you hate it, Uncle? Yeah, of course. But that digital divide is a real thing. I always told you about my case if you was currently with the Air Force, flew 747s, those are huge big planes back then, 2 4s, Flukies couldn't figure out this email. Couldn't figure out. In fact, what you couldn't figure out was the autofill function. I agree. I hate that. Here there's the autofill, but he couldn't figure out how to turn it off. And he said, so that every time he tried to email the office, it autofilled the wrong email. Well, you never get my emails. It's like, Clark, it's not my fault. You asked your daughter how to turn off the autofill. I didn't know how to do all that. And I did say, you're curdling Air Force. Obviously a smart guy could fly a 747. You can't figure out autofill. And there is that digital divide, I think, that adds to the isolation. And let's face it, at some point I've had to tell patients, you can't figure this out, you're not a good fit for my practice. I can't change my whole practice because you can't figure out the computer. And it's not going away. It's only going to get more and more and more and more and more. So that's a definite problem. You will go ahead. Thank you very much. So certainly rising health concerns associated with seniors that as I shared with you before, it's never normal. If we do see it, we need to treat it, and it's worthwhile to treat. And why? And you can go ahead. Oh, I mentioned this about some of the issues, particularly seniors, that digital divide, feeling isolation, growing medical concerns, fear about going out and being hurt. Maybe not so much in Collin County, but I went to school in New York City. No cars. You have to take the train, the subway. Worried about being mugged or tapped somewhere out on the street. Those are real concerns that add to that isolation. And why are some of these things a problem? Let's go ahead, Mama. Oh, okay. Because it shouldn't be treated in isolation. Remember I was saying to you before that depression affects every medical illness that we know of, the morbidity and mortality of it. If you're also depressed, the morbidity and mortality can skyrocket. And that's important too, because I did want to talk a little bit about suicide. I think that's the next one, thank you. As a silent crisis, 12th leading cause of death in the United States is suicide. And it's a uniquely human phenomenon. Dog doesn't realize that it hasn't reached its potential in life. He decided to jump off the balcony. Quite the opposite. It really is a decidedly human phenomenon. I'm not talking about the mother grizzly protecting her baby and gets in the way of the bunch. I'm not talking about things like that. I'm talking about jumping off the roof. It is a depression. 12%, the main cause, the main method is suicide in people 15 and under is asphyxiation. Which I think is horrible that we even have a statistic like that. At 15, asphyxiation? Yeah, it is awful. We need to treat some of these things. Emil Durkheim was a sociologist in the 60s, and he was one of the first people to begin studying suicide. And what he thought was that,
You know the 1960s, though. They just say. You're very the night.
What year, okay? What, yeah, parents. Interesting.
and what he thought these social isolation adds, and he was a sociologist, so he was looking at it from a sociological perspective, but that isolation added to the risk of suicide. And he posited, his thought was that men are more socially isolated than women. In men, that usually their best friend is their wife. Women are all sorts of friends. Girlfriends this, girlfriend that. A lot of complicated relationships. My girlfriend is like 5 or 6 girlfriends that she hangs out with. It's like a truly best friend. I'll have many other friends except you. And as we keep hypothesize that, and you hypothesize older people as well. And those are exactly the statistics you see. Suicide is highest in people over 85, followed by people under 70 or over 75. And it's that social connectedness, all those things we were talking about before. And we know that depression adds to that. So I don't want to treat it. I did want to spend just a few minutes. I'm conscious of the time. Danielle said we have 5 hours. Yeah. As you all can imagine, I can talk for about. But I did want to share a little bit about what we do with TMS. You know, the FDA approved TMS 18 years ago. 18 years ago. That's what, and I tell people a little bit about TMS, transcranial magnetic stimulation, and they're like, "Oh, I don't like these new things." New. It actually was approved by the FDA 18 years ago. There's nothing new about it. You hadn't heard more about it because of big pharma.
Right.
And insurance coverage. And actually beginning about 8 years ago was a use. So Medicare began covering TMS. And to me, that's actually and I think everybody in this room knows who works with Medicare. Just because the FDA approves something doesn't mean Medicare's going to pay for something. That's right. In fact, often very rarely. The fact that Medicare does pay for it is a huge endorsement on the safety and the efficacy of the procedure, which is really. And when Medicare began is covering it, a lot of the debit insurance companies began. So it's actually pretty cool. And you'll see it or know about what we do at Salience or seen TMS. But if I could just spend a couple of minutes about it, the brain is a chemical electrical tissue. You've all seen the Matrix. I'll stop thinking about it. I won't click on that brain. Yes, sir. Okay. There's a part where Lawrence Fishburne says, "This is all you are to the Matrix with that." Essentially, he's karate. Humans aren't good at. He's ejective heat does an awful lot. You don't make that much electricity. But essentially, he's correct. The brain uses compounds the size of a membrane to generate electrical current. And because it's electrical as chemicals, we use chemicals to hopefully improve that signaling. So whether it's coffee, caffeine, whether it's fill in alcohol, whatever you want to fill in the blank for chemicals, sensibly people are trying to use it to mitigate that stability of the brain. Hopefully they increase it, although sometimes with alcohol or other drugs, maybe to change it the other way, but to mitigate it. The problem with drugs is they don't know to go to the part of the brain where depression and anxiety. They go everywhere. They cause side effects. It would kind of be neat if we could aim the fit. And a fellow named Michael Faraday actually figured out that you could aim a magnet. He figured it out in a neat way, by the way. You all know named Michael Faraday? He was a Scotsman, and he was on the faculty at Oxford and Cambridge at the same time without a college degree. Mm-hmm. He never went to college. You're like Abraham Lincoln. Never did. What he did is he liked to play with magnets. And what Faraday figured out is not just that you could aim it. I mean, we all know if you break one magnet this way, it feels like that. You turn it around and it feels back. What he figured out, though, is they're all right-handed. You know magnets are right-handed? And by that, I mean, I know you all know the righty-tighty, lefty-loosey, where you're working with a screwdriver. It's the law of the universe. If you spin a magnet with your left hand in the direction of your fingers, just like a screwdriver, the electrical field goes in the direction of your thumb. Righty-tighty, you spin it this way, it goes like that. There go left-handed magnets. Even if you spin it, for me, this is clockwise. Spin it clockwise, the field goes towards opposite. It's kind of cool, actually, isn't it? That's all power stations are doing. They're spinning magnets around a wire. And if you spin a magnet this way, the field goes that way. So kind of cool. Essentially, what I can do with a magnet is aim it. And I can aim it at that part of the brain, which we believe plays a role in depression and anxiety. And essentially kind of turn it off without tranquilizing the person. I think that's why people develop problems with alcohol. We just like to turn that off. Yeah, but it turns off everything. That's especially the coordination. Sometimes, but yeah, I'm talking to both of you. Yeah. It turns those things off too. It'd be nice again if we could aim the truth. And that's what we do. Our seniors like it because there's one fewer drug they have to take. Our seniors like it because side effect profile is minimal. It's an extremely well-tolerated procedure. So, and there's also increasing data that it can help people. You use the term pseudo-dementia. You all heard that? It was developed by an Australian psychiatrist back in the 60s, because what he wanted is not for seniors not to be labeled as demented when they're really depressed. So we developed the concept, well, they've got pseudo-dementia. They look like they're demented, but they're not. They're really depressed. It's actually become pejorative now because anybody who suffered from depression knows there's nothing pseudo but the cognitive point.
That's right.
It's real. It's absolutely real. So it's become a little pejorative. It's kind of like many of you might know that in the history of psychiatry, moron, imbecile, and idiot actually had definitions. And you could actually, Neil and I could discuss, well, I don't think I think he's more like a high-grade imbecile. And we can actually have a meaningful discussion about you. It's like Jimbo. We don't use terms like that anymore because of pejorative. The same with pseudo-dementia. But the point is that it affects people coughing, depression does. So treating that probably helps them cognitively. I think we've got a couple minutes for questions. I was mindful of your time. Am I hearing your head on you? Yeah. Well,
So do
we have time? Yeah, do you?
absolutely. So part of your slides with
Stop me.
around access, do you take Medicare?
Yes,
Okay.
absolutely. Oh, I'll just go. Yes.
So you're talking about how the magnets, the therapy can affect cycle.
So how was the last and after the?
That's a point day for us. We actually have some of the best statistics in the country. And I know that because I go to Beaks. And I know that because people from around the country, like Stanford, come to us for data. I know that we have some of the best students. And a lot of that is because our treaties are proprietary. We have a medical board with somebody from McGill, somebody from Southwestern. I used to be, but they kicked me off for something. A medical board, Dr. Slaughters on the medical board, okay. Coming up with these protocols. These protocols are ours. We've come up with. How long does it last? About a third of people within a year need another round. But what they tell me is it's not as bad as before. And they respond a lot better this every time. And for so many people who've been depressed for years and years, I said, if I could give you a year of rest there, from depression, and maybe next year you have to come in for another treatment, because so he's a pesky little bear. That's great. And probably it goes from there. Getting better. Then 85 years. And then 10. Like follow-ups.
So what's the mechanism for it lasting?
You're right. I probably have a Nobel Prize if I ever should exactly. But probably has to do with things like neuroplasticity.
Yeah.
That is how we change the brain and how I say this, it's a little imprecise, but it's descriptive, certainly for me and for my patients. It's like rewiring things. Because the center of retargeting in the brain, there is no depression center. Right. There is a. Right. I sometimes think there's a Mexican food center in the brain. I had guacamole at both sides light up, right? No, there's no depression center, but there is a Staley as a third center. That's how we pick our name, by the way. There's a Sadian center, and by that I mean, how does the brain figure out what's important to focus on? Why is it that some people can forget Mary Louise Opperman, left key, That prom night stood me up back at prom, and other people like, oh, you're still upset that. But you know, there are people like that. I have a couple that come to see me, and she is still bad about something her mother-in-law said in 1970 at their wedding. So man will break you up the coals over. He's like, first of all, she's dead. Secondly, have I done worse things? I'm so. But her brain, her salient center, is stuck on that, telling her that's salient and germane to the present. While he's like, it's not germane at all to the present. That was that was 55 years ago. It's that salient center. Actually, what we're doing, the mechanism, is by stimulating it, we're sending it in for refraction. Yeah. By refraction, essentially turning it off. And we keep doing that. And the idea is that in 2025, the skills you didn't have 50 years ago, you can kind of reconnect what's saved. You can be in charge of what's saved instead of your salient center telling you what's saved. And you've had a question up with you.
What does TMS stand for?
Transcranial Magnetic Stimulation.
Yeah, I was going to ask, so I know more so for the senior community, but this also helps out with post-traumatic stress, veterans.
Firefighters, please. Keep, and I
Just speaking from personal, this actually helped me. I lost my father in Afghanistan back in 2012. So going through the magnetics, it was a process by 18 months. So this hits home for me.
yeah, but they use chest. Because my brother was up to. If you think about it that way, salient center, just like he was saying, plays a role in most psychiatric pathology. PTSD. Why could you're not in Vietnam anymore? You're at home with your wife. That sound was not gunshot. My salient center turned on and said, be ready. I'm back in Vietnam. It's all over again. It's the salient center. Why is it that some people, even if you don't like math, you can study 30 minutes to pass the test? That's all you got to do. Does Ellen do that? Is it?
I get them. Yeah, docket attention disorder, those kinds of things. Our TMS is actually the first time I ever heard the term was some homeschooling families that were using it for their TADH, especially T-boys.
So
were using it.
the Sanford group, actually, I look at their website a lot. They have a lot of neat data. They're using it for pains and
Yes, but that's really sad.
And if you can make it less salient, does it really hurt?
Yeah.
Yeah. I remember when I was a kid, my grandmother had the stiletto, high heels. Remember those? So it's a grandmother. I was probably 7 or 8, and I tried them on, tried to walk, and they hurt horribly. And I asked her, how do you put up with that pain? And she said, well, women, they don't think about that. They think about how their earrings are pitching at you. She didn't have to ears. She had the clip-ons. Oh, right. And the point is, sales. I ignore my feet. I do it because she's in charge of the salient center. What if you're not in charge of your salient center? It's telling you that, hip fracture or that's the fibromyalgia, it's really bad. Your salient center is saying it's bad, it's bad, it's bad, it's bad. Well, what we could do is break that. We can put you in charge of the SAIDs. So kind of cool. Oh, yes. It'd be okay with use.
I have a patient that they did brain stimulation. Is that kind of the same thing? Because it helps with his Parkinson.
Absolutely. Deep brain, there are a number of mechanisms, including vagal nerve implant. And you probably know this, most nerves come off the spinal column. And did you know your spinal cord actually ends at about the level of your scapula? Some people think it goes all the way down to your back. It doesn't. It ends probably about right up here. Nicholas? Yeah, that's why people can be lumbar punctures, because you're not going to puncture the spinal cord. The spinal cord stops growing about the time of when you're 2 or 3. What happens as we age, the nerves get stretched. You don't get more of them. They get stretched, and they get longer and longer. And actually, when you look at it, the nerves, as they come out of the spinal cord, they go like this. And someone and I measured life dictionary, they call it the cauda equina, which is Latin for the tail of the horse. And you all know how the tail of the horse looks like that as the hair comes out. That's the spine. That's what nerves coming off the spinal cord. In fact, they really do get stretched. The longest cell we know of is in a giraffe. There is one cell that goes through his brain all the way down his back, the synapses cleft, which is probably 8 feet long. One cell, 8 feet long, and probably a micron. Why is he doing this? But there are 12 nerves that come directly off the brain. It's the brain's way of getting immediate control. One of them is called the vagus nerve. We call it the vagus nerve like vagary or vagrant. It wanders. Goes to your vocal cords. You're speaking with your mate. Goes to your heart, it goes to your lungs, it goes to your gut. It's a way for the brain to get immediate control of those things. So I'm trying to think out. So vagal nerve stimulation can work because you can stimulate back up. Deep brain stimulation can work, especially using the magnet is a lot less invasive than opening up someone's sticky ears or opening up someone's chest and attaching a stimulator to the baby's nerve in their neck.
Very easy.
It's a lot of
Or an object in your body, and then you have breast burn section, and
absolutely. Was there another question? Oh, Jordan had a question, and then up into you. Sorry.
So I worked in mental health, and we had a lot of clients that they tried a lot of medications and they were medication resistant, so we would take them to TMS. But one thing that we did have to do is we had to make sure that they could do a session every single day for almost 2 to 3 weeks at a time. So if we're talking in regards to seniors, how do you foresee that being applicable, essentially?
Jordan did ask, and it is true. TMS is a commitment. It is a whole lot more convenient to take a pill. I mean, similar to the Birkenfeld pill, we control menstruation for years. Psychiatrists can be a chill if a woman could take once a day as opposed to going to her doctor once a week for a shot. It's a lot more convenient to get it at a pill. That was the revolution of the pill. Not that they figured out how to control menstruation. It's that they made it convenient. It's very convenient to pop a Prozac every morning. What Jordan's alluding to, and it's true, is time commitment, but so's your health. And all this is. And when I tell people this is commitment. If we're going to do this, our treatments last about 15 minutes. As Jordan pointed out, I want you to commit to one treatment a day, 5 days a week for 36 treatments. There is growing data, actually, that more people get more better, more faster if you do more treatments in a day. Really. Now we're actually doing some studies where we're doing all the treatments in one day.
Oh, wow.
And it is true, pardon the lack of grammar, but more people do get more better, more faster, more quicker. It really is. The problem is that Medicare will pay. Medicare will only pay, as people will only pay for one treatment a day.
Well, then you have the issue. There's also the contraindications because people that are diagnosed with dementia, like Alzheimer's dementia or temporal dementia, they should not be taking some of those psychiatric medications at all. So it's actually making that worse.
And I think Ivy's got a point. We're trying to improve cognitive function.
Right.
And you're giving something that makes brain fog worse.
Right.
So it would be neat. And that's why, I like it when I can tell my patients, hopefully it comes across, I just don't want to throw pills at you. If you need it, let's do it. And a lot of people say, I can't make that. Okay, I understand. But I want to just do that because all of them have side effects.
Yes, it is.
I'll do. I caution people if there's drug without side effects, it doesn't work. Doesn't work. Any other questions? Give that question.
I was gonna ask, based on what you just said, for patients that have comorbidities, the depression, the dementia, and all the other stuff, and it could take a medication, but that has side effects of this. So when you do the TMS treatment, do it stop all the get off your medications?
She asked about concomitant medications and concomitant free use. I like people say on exactly what they're on throughout the treatment, just because it limits variables. If we change too many things all at once, I won't know.
Or was it because we changed the Transcranial or Prozac?
Yes.
I won't know. So I try to limit the variables. But what I tell them is my primary goal is to treat your depression or your anxiety or whatever it is. That's my primary goal. My secondary goal is to do as little medicine as possible. And wouldn't it be if we could simplify your regimen? And that's my secondary goal. Another plug for TMS and seniors because they're already on. What is the Beers criteria?
Yeah,
And they
45 to 30 drug.
like it's actually 20 to 30. That's good day. Absolutely. If we could do it with one without another drug, love my patients like that. So, any of your thoughts? Do we have
I think
any other thoughts?
time. So let's give Cryptic